So we continue, and I would like to invite Natalia Rodionova, Yulia Zmievska, and Volodymyr Panov up here. Please take your seats. Dear friends, just like as we discussed, we continue. It's too sharp, and we start our panel discussion about the ban and legal responsibility and liability to document virginity status. And our respected panelists, I would like to say a few words about each of them. Close to me is Yulia Zmievska. She is the head of Luhansk Oblast Office of Forensic Expertise. Welcome, Mr. Volodymyr Panov. So it's better for me to read. He is a doctor, OBGYN. He is instructor, and he is a coordinator of OBGYN and reproduction at Julian Allen Training Center, and also Natalia Rodionova. And we have met her, a lawyer and also an expert on minors and standards on how to deal with children who are in conflict with law. Also a member of Association of Women Lawyers in Ukraine. So thank you first of all for coming here, and I urge the whole audience and all the participants to put your questions to our experts, and also those people who participate online on YouTube, please write your questions in chat. We are going to put them and voice them as well. And at this point of time, I would like to hear from each of the panelists. I'd like to hear your expert opinion, being a specialist, an expert in your area. What do you think about virginity status in general and about documentation of the status? Why we are talking about that? This is day one of our conference. We are talking about rights, the rights with regards to sexual and reproductive health. So does a practitioner, medical practitioner, has to determine this virginity status and put it as part of any medical records. So is there a right in the healthcare that a healthcare practitioner might enjoy? Thank you, thank you, thank you for inviting me for this event. I'm from Dnipro city, and probably a lot of people know about menorah in Dnipro. So just a question to your question. So why and what for? So what does this 1 September, some have obliterated hymen. So there are lots of situations. And there was a clinical situation, a girl, so during a judging by her age, she was supposed to have menses, but no menses. So she comes to a gynecologist and the hymen is there. So what we have to see that it was absolutely obliterated. So hematocolpus, so the vagina was filled with menses. So what was the volume? Can you guess? 900, almost 900 milliliters. Yeah, so in principle, if we'll just look at the anatomical structure, it's not a justification, a ground for us to say anything about the virginity status. Maybe you would like to add something. I understand all that about the status and everything, but I have a question to law enforcement, to advocacy people. So what if a girl comes to you and for some reason, I just know that some of my colleagues, they want to learn and they go for trainings everywhere, but some other people do not want to study more. So they graduated in the 90s and they believe their level of knowledge is enough. So, okay, a girl comes and says that there was a sexual violence on part of her stepfather. Okay, so that's what she claims. And if a doctor doesn't know anything about that, but if a doctor doesn't know modern information, they start to do all kind of checksum and expertise. But legally, there is no influence, even if they write somewhere she is a virgin. Well, still, there is a sexual violence. Yes, absolutely. And just to repeat, there are different types of violence, sexual violence. So I have a survivor, and according who was like the violence was anal violation. So even if you write a document with like a certificate saying the virginity status and such, I wouldn't even use them during the court hearings because it's not a proof to me. The grounds is the conclusion of forensic specialists, psychologists, and their conclusion, and also the green room, and also the child's evidences, also what the child says. But this information about virginity status is something that I don't need, nor any adequate prosecutor investigator needs. So it doesn't matter. Maybe she was a virgin or she was not a virgin at that time. But if it is a crime and violence that she was subjected to, so it's still a crime, regardless of the status. Thank you. Thank you for this answer. And you try to understand, to explain to some people that it's not important, and you tell them about that. Yeah, we need to talk to them and explain to them very often, because sometimes we can read and see the conclusion that some doctors say that there is no signs of penetration, but whatever can penetrate might be a different size, different things happen. Because sometimes, like no witnesses, and there is that virginity status document, and they think, well, no violence. So sexual violence is only penetration or major nakedness. So sexual violence can be with penetration, without penetration. It can be kissing, touching. That is also sexual violence. It's not necessarily that penetration is the rape. Yes, it's penetration, not just with sexual organs, hands, or other objects. But sexual violence is not always with penetration. I just wanted to add with regards to the issue, according to the criminal code, rape is penetration, but sexual violence, it says that excludes penetration. So any actions of sexual character or nature that would not followed by penetration. It's a separate article. Criminal article should be viewed in a different context. Thank you. Just wanted to clarify with regards to, for example, when girls come to appointments. So we always ask them whether they have sexual life or not, and we have to put such questions just for further diagnosis, examination. We might ask, but whether we have to put that information in her medical chart. What for? What for? Well, for further information. She comes in a year, say for example, nothing has changed, and I understand that it would be enough for me just to talk to her, maybe sonography, like abdominal sonography, maybe do some tests if there are some complaints. So that is going to, for me, a basis whether I should or should not do the gynecological exam. So, but in general, in overall health record, just for me to plan any further examination conversations. Thank you for your answer. You are right that early beginning of sexual life and multiple partners are risk factors, including for cervical cancer. So we need to ask about that, and it's evidence based. Yes, asking about that and answers are really important. Number two, you are not documenting the virginity status. You don't need it, but just for you, for yourself, you understand that she has sexual life, and you just develop your policy. So we don't have to put it in her health record. No, you don't, because it's a confidential information. If it's a outpatient health card, and everything is part now of an overall electronic medical system, and usually it's not a doctor, for example, who enters the information, then not a doctor but a nurse. And for the nurse to know that is already breaking confidentiality disclosure. Well, and when I ask one of my patients whether she has sexual life or not, she says no, but there are complaints without any speculum. We took some tests, specimens for tests. Again, I ask whether there was a sexual life or not. She says not now, but in general, yes, I had it before. So, so there was an actual case. So she said no sexual life, but she never mentioned that she had it before. Okay, another question. I just wanted to add, you have the right to put, put information in the health record whether there is a sexual life or not, because it's an experience. So you're getting history, but you don't officially document status, virginity status. You need the information, yes, you can put it as a part of the health record detail, but you do not have it as a status. Another question. So a girl actually is a volleyball player and the partner is a volleyball coach, and they come to me because those children are adolescents and was not quite clear installation. So with a request whether there was or was not a contact. So the father was on the phone, mother was somewhere in a different country, so they came whether there was a sexual contact or not, just to be able to take this guy to court. So I said that I don't have a right to do that, and I referred them to forensic specialists. Did I do the right thing? I think that in this case, if it was, she was a minor, 14-year-old, 14. Okay, so you have the right to do the examination, but again, no legal evaluations has to be done. I always say that you have the right to do the examination. Mm, the procedure of documenting all sexual violence is quite traumatic. This procedure is traumatic. And so you have to come to a doctor, then the forensic person, then the investigator. For children, it's very traumatic. If you understand that your qualification is enough.
And we are going to have the next session. Anna, thanks so much. You have already started talking about this medical confidentiality or medical secret. That was just the start or the teaser of our next part of the meeting. The next topic is going to be the following. It's going to be physician-patient privilege, legal issues in protecting patient rights, and medical staff accountability. So Natalia Rodionova is going to talk with us on this topic. Thanks so much for joining. And for you, it is going to be extremely important to take a look from two different sides on this topic as a medical professional, but also as a potential client of healthcare facility. I don't know how it works for you, but all of us are citizens of this country, and each one of us might address to colleagues and to other healthcare institutions. So you need to be aware whether your secrets are preserved and whether they are confidential and what kind of consequences it might have. So let's try to talk about it more in details. Please, Natalia. So we are moving to the medical secret, what it is and what happens in case you violate it. So we are going to start with the following. The understanding of the doctor's secret or medical secret, that's information about the state of the health, about the reasons for addressing the diagnostic procedures, and also the consequences and the results which we obtain. And also this is the information which is not medical, but what we find out and what we need to find out from the patient in order to identify, according to the symptoms, according to the lifestyle, the proper interventions and treatment management plan and what might happen with this patient. So, doctor's secret or medical secret, it's not only about healthcare professionals such as doctors. It also covers non-medical information about the personal life, about partners, about family, about habits, about negative habits. All of that is going to be included within the term of the medical secret. So it's not only about the patient or healthcare institution procedures, like diagnostic interventions. All of this disclosure of the non-medical information, it also leads to the consequences, criminal discipline consequences, but also the civil responsibility. It might be rather huge fees which might be done in a moral injury as a result. So we talk about the secret about the state of the health, about the patients, and about those who address to get consultation or counseling, treatment, interventions, any kind of medical services. It is being established, first of all, by the Constitution of Ukraine. That's the basis, which gives us the information about the secret of private family life. That's also European heard about the rights of the patients, also the Civil Code of Ukraine, which gives us this information. That's also the Criminal Code of Ukraine. Responsibility. According to the Criminal Code of Ukraine, this law of Ukraine about information and responsibility actually makes us not to disclose this information. And we are talking not only about healthcare professionals, but also we are talking about those people which have some contact with this information or they support the healthcare institutions or doctors. So it's hard to talk about it. But what we have IT specialists, we have registry workers, other stuff. And information is not controlled in a lot of healthcare institutions. And this information flows from one office to another, from one room to another. And this is where we need to establish some kind of personal awareness of all employees, that they need to understand and they need to know the consequences and responsibilities for disclosure of different kind of information which they are aware during their non-medical activity. It is needed to be discussed and it is needed to be written formally in order for us not to have any kind of other questions, because someone might mention that, but as a result of not preserving the secret, the patient is going to come with a lawyer and they're going to address whom they're going to address, healthcare professional. And there is a question how you as healthcare professionals are going to protect yourself in case someone who is not dealing directly with your management, with your counseling, how you're going to make yourself safe in this situation. Also, the law of Ukraine on information, which was already mentioned, which identifies the confidential data. Also, the law of Ukraine about the urgent health services, and also law of Ukraine regarding the basic legal framework about the healthcare. What I would like to say, it also needs to be mentioned, the code of ethical behavior. It is needed to be mentioned, but it also needs to include the information about the attitude, about the respect to the information. Also, in case we're going to take more in details, the secret on the status of the healthcare, it is first of all established by Article 286 of the Civil Code of Ukraine and also Article 39(1) of the Law of Ukraine on the basic legislation on the healthcare. And it provides a physical person, patient, right to have the secret about the status of the healthcare, to have the secret or confidential data regarding the having this counseling diagnosis and all the data which were obtained during the medical investigation. And also it is forbidden to disclosure this information by non-medical professionals. So medical secret is not just about medical data or the results of our medical interventions. Besides that, we also need to remember about that. It is forbidden to provide data which some of the employees like to use to provide information about the results of the treatment. So in case there is a request where patient works or from the employee of the patient, employer of the patient, we may just approve that this patient was treated or was not treated. But we cannot identify the diagnosis of the patient, why patient was treated, because once again, that's disclosure of medical information. And there is a positive legislative cases, court cases, negative for healthcare institutions, when I don't know the reasons why, but it was identified during just the period of time, and there was no other information. The employer addressed the healthcare institution that during a couple of months, employee a couple of times was treated in the healthcare institution. There was some doubts whether this patient was really treated or whether she was not. And in fact, healthcare institution has provided information about the diagnosis with which patient was having. Then this patient, the disclosure of whose information happened, she addressed to the court, and she had also a positive outcome of the court. You need to remember about that. The employer request, it does not somehow influence the right to be protected regarding the disclosure of their diagnosis. Sometimes it might be used by lawyers as well. They create lawyer requests in order to discreditate or negatively influence their opponents or just to get some kind of negative characteristics regarding the opposite side. That is something which is also needed to be taken into attention. Request from the lawyer, it does not influence the medical secret. We may only provide the information in case there is the consent of the patient and in case this lawyer represents the interests of this patient. In case these are opponents or some kind of people who have nothing to do with this patient, it does not lead to any kind of consequences for us in case we do not want to provide this data. And sometimes the lawyers, they request information with this data that there is a refusal of information and it is going to lead to administrative responsibilities. No, please pay attention who requests this information and whether this request from the lawyer comes with the patient's consent and whether this lawyer is the representative of the interests of the patient. And in case there is no consent, and even in case lawyer says that he or she is representative of the patient, please provide an answer that there is no consent from the patient to disclose the information, and that's why it is impossible to provide this data, and it's not going to be a violation. It's better for a lawyer to address you for the second time with all needed consents than you are going to have any kind of issues further in the court from this patient. Also, you need to not disclosure the information as a result of the professional activity. So you do not need to disclosure this information. And we are talking about employees which support the healthcare professionals, which support patients, but they are not doctors or they are not healthcare professionals. So it also covers them. It is needed to be mentioned to them. It is needed to be explained. It's not only your reputation, but it might also become your responsibility. It's better for them to understand everybody who is in the healthcare institution, to understand what they may do and what they can't do, and also to have written kind of instructions for them to follow and to adhere to the confidentiality and disclosure of the information. That's also once again regarding the law on information, which was mentioned previously on the slides. Also, we do have an understanding of three main points of the medical secret. First of all, patient should be aware on all the information about the state of the health. How usually it happens? Somebody is afraid how the information is going to be taken by the patient, and they say that they want to talk with the relatives of the patient, but that's not needed. Some doctors do not provide all information or provide all information only to relatives. Is that correct? According to my opinion, from the legislative point of view, it's not correct because you limit the understanding and the adequate understanding of the status of the patient. And for patient also to identify legislative or even kind of other actions which are needed to be taken to make it easier, for example, for relatives. And from the other point of view, from the ethical point of view, yes, sometimes patients might be in a state that this information might lead to some suicidal cases, for example. But from the legislative point of view, we need to provide full information. From the human point of view, we still need to individually evaluate our patients and to have individual approach, because sometimes we need to involve a psychologist probably to understand the diagnosis, to understand the prognosis, and also approaches. Sometimes maybe it's better to do together with with relatives in case patient allows relatives to find out their information. But from the legislative point of view, we need to provide full information. Do not need to hide anything. And it doesn't matter how hard it is to talk about the diagnosis. That's the right of the patient to know everything about his or her status, disease, treatment, and possible prognosis. Second point, all medical and non-medical information about the status of the health of the patient is medical secret. So doctor, nurse, any kind of other employees, maybe this was just some kind of other people which for example, internet connection. They were fixing the internet connection in the office, and they have seen something, or they have seen some databases which were filled in, medical informational databases. Everybody who finds out the information, they are fall under this medical secret. So in case we involve any kind of secondary specialists, contractors, and in case we have those contractors in the healthcare institutions, all of them, those contractors should sign and should be aware on the documents and on the fact that information that they find out is a medical secret, and this is the medical secret of their employee of this healthcare institution. That's important because sometimes when we try to find out where is the point of the leaking of the information, it happens to be a lot of other people. Also, in each separate case, as I have mentioned previously, we need to talk, we need to inform. The best way to do it in a written manner regarding the possible consequences, possible responsibilities, and about the medical information. For everybody to be aware, for us not to have any issues in the future, for you as a doctor and for the healthcare institution which you represent. Besides that, medical employees, they need to have the confidentiality of the patient, the anonymity of the patient, and in case the information which was obtained and the information is used during any kind of lectures, maybe any kind of articles, we need to take into account that there is no possibility to identify this patient, that all the data is anonymous. In case we print any kind of pictures, for example, of injuries, of disease, maybe rash on the skin, and this person might have some kind of identifying moles, identifying scars or tattoos, we need to blur all of that. All of that is needed to be blurred. Only in case of the informed consent, we may use this data in order for us not to have any kind of issues regarding the distribution of this data and information about the patient, or even the distribution of information, because it is all violating the medical secret, and you need to have the consent of the consent of the patient to use this data. It is needed to be mentioned. It is needed to be mentioned that this information is going to be shared, for example, in an anonymous fashion, but it is going to be without any way to identify the patient. And in case patient refuses, we cannot use any kind of those pictures or any kind of that data. Moving further, we might say that any kind of a medical secret, it also has responsibilities and it also has exclusions when it is fully legal to disclosure some information. And of course, there are some identified cases by the legislation, and we need to adhere to those requests. For example, lawyers' requests or other requests. These cases, when you exclude and when you provide the information, no responsibilities are going to be taken. And any kind of court issues are not going to happen for you from the person who is the owner of the information. So, as we have mentioned previously, the information about the status of the health of children younger than 18 years old, because parents have full right to receive the information about their health of their children regarding the results of the diagnostics, treatment, management, and prognosis. We respect the child, their data is private. From 14 years old, they address us, but in case it's a consultation and it requires further treatment or investigation, we got back to this absolute right of the legal representatives of the parents to know about their status. And in case they address consciously, we need to provide this information to parents and we need to make them aware. And it is fully legal. Besides that, in case patient provides an informed consent on disclosure of information, this consent might be provided to the lawyer. It might be provided to have somewhere this information highlighted. For example, some of the victims of the sexual violence during the armed conflict, when we work with them, they sign informed consent. And in this informed consent, it is mentioned that we may anonymously highlight some of the events which were happening, some of the cases which were happening, or to use their examples or their life stories to inform the international organizations. And this consent provides this opportunity. And a lot of people say that I don't want to be anonymous. I want the whole world to know what was happening here. So the same informed consent might be used in order for you to highlight, for example, the situation which happened. Then patient needs to have this informed consent and you are able to do that. Once again, without the consent of the exact patient, you cannot give in any comments. You cannot even tell whether this patient was addressing you or whether this patient was treated by you or any kind of diagnostic procedures were conducted. Because the fact that he addressed you or she addressed you as a patient, it also is the part of the medical secret. Even in case it's a victim and you would like to help and it's an empathy, you need to have an informed consent, because this is the data which cannot be disclosed without the consent. That's the violating of the medical consent. And further on, it might be used by the opposite side. They receive more information and easily out of these open sources might use it. It happens, and it's incorrect. We should not comment anything without the consent of the patient, or in case they are younger than 18 years old, it might influence the court proceedings, and it might have a negative influence. Also, husband and wife, before getting married, they might be informed on their status of the health. That's the case which I have mentioned. Before the marriage, a young couple want to know the results of each other. That is legal, and they might do that, and they provide consent to us. also about the violence in the family. So in case there is domestic violence, we do see that there is a danger to the health or even to the life. We do not need any kind of consents. We just inform police and we inform children services. In case this information, for example, whether somebody addresses you from any kind of proceeding organs or bodies or proceeding authorities, they are also addressing us with the request for this information, and we may provide some of this information. But in case it's not only about the fact of addressing of the patient to us, and it requires some kind of diagnostics of the socially important diseases, we do not disclose it. It's not enough just to have the requests. It is fully mentioned. For example, we cannot answer the request whether this patient has HIV, AIDS. We need to have a court decision to disclosure this information. In case it's a lawyer of this patient and there is an informed consent of the patient, then we might provide this information. Because sometimes it happens that patients, they are under the court proceeding and the lawyer using the reason of the healthcare status, they use this information to ask for better result of the court proceeding. So they start to collect the medical data. In this case, we may provide it in case there is medical consent. In case there is a request without the court decision or without the informed consent, no. We only need to have the informed consent from the lawyer of the patient or from the court decision, whether it is important or whether this information might be disclosed. Also, what allows us to disclose the information, we need to inform about the cases of injuries which have criminal character. It's also a rather unclear.
We are coming back. I understand people might be tired. We still have two very important topics. And also, I would like to invite Hanna Litvinova to talk about gender dysphoria. Not a lot of people know about that. So, medical legal aspects and access to medical services in the context of medical dysphoria. I will try to look what's going on with my clicker. Just a minute. I'm sorry for this technical. Whoever helped me, thank you so much. Once again, welcome everyone. So it looks like it's an interesting topic. Yes, I work with this topic since 2017, and our organization was involved in creating existing clinical protocol. And the name of it is much longer because it says primary, secondary, tertiary healthcare, and in the end, gender dysphoria. Just to simplify, unified clinical protocol, gender dysphoria is something we call it. I just saw two raised hands who have heard about gender dysphoria. That's too little. So we are coming back to the first presentation. I'm sorry to hear that you don't know about this uniform protocol, but actually it's a question to your management. Your management is actually responsible for making you know what's that. So we'll start from the procedure. Gender dysphoria is about LGBTQ community, our organization is protecting the rights of LGBT people in Ukraine. Why we are talking about medical part, but in the context of legal issues, because the Unified Protocol Gender Dysphoria, it talks about procedure as part of medical, part of transition. So everyone knows who is LGBTQI. What is L? And speak out loud. Who says that? And probably orientation has not changed. So the fear to say gay, lesbian, transgender, there is a feeling that you say it and then you get this incurable disease and you'll be like that. So sexual orientation of gender identity is something you don't just contract swimming in the swimming pool. So whether gender identity or sexual orientation of a person and how much it is important in your work, what do you think? Is it? What's the influence? So what's the response? Thank you. Well, there are some reactions that might be really different. We started to hold our trainings for doctors since 2017, and we tell doctors how to work with a unified protocol. We talk about the medical secret or confidentiality. We talk about sensitive uh, terminology. We talk how to talk to clients openly and honestly. I'm still surprised why doctors are so much surprised when we talk about LGBT and trans transition. Trans transition is when F to M or M to F transition is happening. So I can be a female, but I feel like a man, then I'm a trans man. If vice versa, I'm a trans woman. And such issues, it's not does not only surprise doctors, but it's shocking to them. But I'm shocked by that. But you are the ones who have during your training seen any person, any female and male from outside and inside. So sometimes there's hairy legs in a woman. Okay, so okay, and she comes to me. So how hairy legs can influence the process of treating a person? So what if my style of expression is hairy legs? Okay, so if it's not a problem, for a person to talk about that, it shouldn't be a problem to talk about that for a practitioner, healthcare practitioner. So I don't like the word tolerance. I really hate it, and I tell that to everyone because when what is meant is mm, is we have to kind of tolerate each other. We are all different. We have been born in different places, different color of skin, eyes, whatever. But no problem with that. So if we are respectful toward the client who comes to us, so that's the opportunity to understand what's the request from that client. In order for a lesbian who comes to you to you that be able to say openly who she has sexual relationship with, or maybe a person might say not interested in sex at all, because there are people like that. Well, there is a name for that person, for example, asexual. Like, sex is not something that interests such person, and sometimes there is a fear of being judged, because if I say that, maybe I don't get the quality care, or I can be refused care. So I will start from the medical procedure of sex transition, and why do we have the need to change that? There was a case, legal case, when a client came and she said she's not going to change sex because she doesn't need that, but the procedure demanded change of sex. Otherwise, a person wouldn't be able to change documents, changes to the birth certificate, to passport, so on and so forth. So there was a legal precedent, and that was a push toward the need to change the obsolete procedure. It was like punishing and humiliating. There was a committee, several people were there, and the person coming to that commission meeting was asked a lot of questions. So, who does he or she have sexual contacts with? How many times? When? How? When a person mentioned that she already had some uh, surgical interventions, so that commission people, they said, you have to undress to show us. Well, whatever your documents say, we don't believe, we need to see it with our own eyes. So undress. So depending on what kind of surgery was done, so the person had to undress either to the waist or completely. Do you think it's humiliating? And how humiliating that is, do you think? So the level of suicide among people of trans community is quite high. So when we talk about LGBT people, it's quite a closed community. If we talk about trans community, even more closed community within community. So sometimes we can hear from the opponents like it's their whims, that's how they try to do it, not to get conscripted, not to do their military duty. So if we look at costs of substitution hormonal therapy, you understand it's not just a whim. So whatever you might see on screen now, this is how the procedure looked like before. It was necessary to come to a sexopathologist doctor for necessary required examination, psychiatric examination. The requirements towards psychiatric hospital is no less than 30 days, but not more than 45 days. So a person has been in a general psychiatric ward for a month. It's not a separate ward or a separate room uh, for trans people. It's a general department or general ward. There are different people with different conditions there. So what might have happened on part of doctors? Let us be honest. Until now, and even now, uh, psychiatrists are viewed differently, not like other doctors. No one wants to get a psychiatric diagnosis, and that is why very often people do seek help because they do not want the psychiatric diagnosis. As of today, procedure is more simple. So it's outpatient follow-up for 2 years and not more than 14 days in the inpatient department. This is according to the legislation, current legislation. It's either a person chooses or a psychiatrist makes a decision whether it's necessary. If uh, the socialization was for a couple of years in a person, then a doctor who is experienced in following such patients can make a decision not about 14 days and not about 2 years of outpatient follow-up. So if a patient is socialized for 5 years as a woman, so why would we follow up on her for 2 more years? But still uh, this condition is there, this prerequisite is there. So there is a term of nuclear transgender, and so when a person did everything and for a long time, for many years, couple of years, has been already socialized in a certain identity, like as a man or socialized as a woman. So as of today, a person makes his or her own decisions whether he or she needs a surgical intervention or not. The only important medical intervention thing is substitution hormonal therapy. In this case, that means being followed by an endocrinologist. but only after transsexualism is going to be diagnosed according to ICF, ICD. I'm sorry, ICD. So, considering that our topic is about reproduction and reproductive health, what does it have to do with transgender people? And you can see the last item, the psychotherapy that was done was aimed and at the patient to refuse from correction, from transition into a different sex. For example, if a person has depression, so that could be directly linked to gender dysphoria. As of today, this item is not there in the procedure. So it's not there, but whether people are still refused, yes, they're still refused. This is an example of lesbians. How to put it mildly, I'm just thinking. So the society is more allowing, like more okay with lesbians than with gays, because watching girls is nicer than watching those terrible boys, as the society thinks. So yes, they explain it's bad, don't do this operation, it's so bad, don't take hormonal therapy. So again, going back to communication, person is not told about impact of hormonal therapy in order for the person to make his or her own decision. Do we have the right to try to talk the person out of this or that decision? No, because a person wants to reach the goals that he or she makes. Surgery, we've mentioned surgery, surgical correction. Previously, they would just mention that after surgical correction, it's not possible to have your own children. Today, in unified protocol, it says that it's necessary to inform about available reproductive opportunities, whether such a consultation is received by these people in maybe in 20% of cases, and only in case the client asked himself or herself. Irina was mentioning burnout, about deformation or deformity. When we come to for the contacts of friendly doctors or legal counseling, I always tell and I always remind during trainings that people are everywhere. Policeman is a human being. Doctor is a human being. It's a person. It's a human being. And sometimes it's quite difficult, for a doctor to be professional and not to include his personal views and stereotypes, for example, discrimination, personal. All that actually that I mentioned is gender-based violence, because gender-based violence is an umbrella term, and within it there are lots of subterms, sexual, including sexual. So the system of reproductive services is quite developed in Ukraine today. LGBT people have that opportunity to go there, to get referred there. Whether it's legally possible to document it, no, because legally they cannot be married. So it's only one of them can go and ask for such services. And still, this is something that was part of the obsolete protocol that was before the 5th of October 16. There was a conclusion or report, medical certificate, whatever you call it, was given to a person. That's the document that was really wanted. And thanks to that, a trans person, could make changes into them ID documents. As of today, the medical certificate about the change of sex correction is given by a family doctor and also has to be signed by medical committee. On the primary healthcare level, it's done quickly, relatively quickly. Well, sometimes this medical commission head would like to see that person. Sometimes they say, well, please come, I need to look at you. Sometimes, again, there are some violations coming back to the confidentiality issue. And during the coffee break, we were discussing cases of confidentiality. I really I feel that we need to use the whole day to involve human rights protecting people and advocates in order to explain how important not to disclose certain information. Because this system should not work like that. It doesn't work like that. Even if the law says who can send you the request and who you can pass certain information to. And if in this document or in the decree there is a mistake in the name of your healthcare facility, even one letter, you have the right to refuse not to take it into work and use it. Use it. But again, Natalia and myself, we can give recommendations, but it's much better when we have a lawyer who we can come to with this issue. And also, the request says that the request should be done within this or that term. So don't try to do it as soon as possible. So, current procedure to change sex. This is the full, complete name of the current document, approved, and it also says when it was approved. I remember when we were going to representatives of the working group to sign this protocol. That was an experience. That was before the beginning of me being as an working as an advocate. But I already had a taste of that. Sometimes they ask me, "How come you became an advocate, like advocacy person?" So because I felt it was really interesting. Yeah, and it is interesting, really. Soon it's going to be 8 years since it became really interesting to me. So by the order of MOH that you can see here, 1041, this on medical, biological, social, psychological indications to change or correct sex in this new unified protocol, there is recommendation with regards to being followed by a psychologist and psychotherapist, because some time passes and there are some options when a person was not socialized before that. Why we are talking about friendly doctors network expansion, I already mentioned, because of this unified protocol, because trans people come for medical care, showed that some doctors, not all, but some doctors have a lot of stereotypes and their own beliefs with regards to trans people. And still we have a myth in this society that same-sex couples, they're just for sex. But if it's a different sex couple, so it's considered not for sex, but just for giving birth to children. So the society does not like the child-free couples. It's considered normal. But in LGBT, families, there are no cases that you get pregnant by chance. No stories like that. So Though this is about the decisions, what do you do and how do you make decisions about your own children. I'm not mentioning even the price, how expensive it can be. It can reach up to 500,000 hryvnias in order to get a child. So we are not talking about caring for a child. It's just for, getting a child. So also approved, you can see a form of primary documentation, the one that I've mentioned. So this is medical certificate form 0663 slash O. You can Google it and get to know it better. And hopefully that after this day, some people will Google. It's more than 60 pages, but this is about what kind of changes might happen after a substitution hormone therapy. And we are just talking about uh, medical situation. The legal one is a different thing. It's a separate journey. So as of today, if we talk about medical part for the patient to be able to complete the uh, to complete their medical part, you need that certificate. So if F64 form is there and changes on a substitution hormonal therapy. So just using the form, it's not possible to use it, but changes need to be there. For endocrinologists, it's a wonderful information. We talked about different collisions, but this one is another topic for them. This is something that endocrinologists, they don't use that coding. In order to prescribe hormonal therapy, female hormones to a man, what they do, they find a way out with regards to the coding that they use. Because we are talking over the prescription drugs. But because of complexity, because of the high cost, sometimes there are some cases that such drugs are brought from abroad or self-prescribed. Ms. Natalia was talking about different chats. There are special chats, and they share their experience. What kind of hormonal drug, in which doses have to be taken, what changes take place. Special categories, minors, because the diagnosis coding for minors is different. Today we are talking only about adults. Unfortunately, speaking about the endocrinologists working in this area in Ukraine are too few, scarce. For many people, it's not interesting because during the education, nobody teaches us about hormonal therapy for trans people. So you have to be interested as a doctor from the scientific point of view or just to support the patient who come to you. So it's more about a self-education when you want to undergo different international trainings on that issue. And of course, it's a paid story. So in our organization, we have a quite a limited pool of such doctors. But there are some, and they help. And there are some endocrinologists working with children because the hormonal replacement substitution therapy is kind of reverse therapy. Reversible, because for adults it's irreversible. What kind of documents are necessary for the family doctor to give that medical certificate? Also, those are approved forms. But how doctors can fill them out, and there are so many mistakes doctors make when filling them out, so please look into the instruction. The instruction says how to fill that out. So if the instruction says that you don't need a stamp, Don't put a stamp. So just a signature, that's all. And your own stamp does not have any legal force. Uh, Previously, in order for me to make a stamp, you had to bring a certificate to show that you have a medical education. But today, no. Well, I need a stamp. I can get any stamp I want. So when patients come and they say, I need a certificate, but we all have to be alert what kind of certificate. And also we have to use the correct terminology. Sometimes they have, I just need a simple document, but what in fact they might need is a special form of certificate. It's not that we come to doctors and tell them how to work with LGBT people. It's a two-way story. It's not possible that there is, for example, a respect shown only for, by patient towards a doctor. It should be two-way. Today, if we talk about LGBT and trans people, we are talking about a vulnerable category and should be both ways. So how much and what does it take for a trans person to finally come to a family doctor to get that certificate? It might take several years for them to become ready to do that. I have a client, a female client, almost 60 years of age. Person came to me, so there was a request for legal counseling, and he says, well, I was divorced, the children are grown up, I want to live for myself finally. And it's a pity we don't know how much time that person still has to live. And especially during the war times, there's um, no prognosis possible. How come such things happen? Judgment in the society because it's not the way it should be done. So it's a bad thing. You have to rethink your decision. Uh, what if a law is going to be approved with regards to civil partnership? Probably it's going to increase in geometrical progression. So it doesn't work like that. We are talking about implementation and realization of constitutional rights.
Just some rights because of the sexual identity or gender identity cannot be implemented because of the absence of the legislative framework. And so it's a pity when person cannot live their lives because of judgment. You as healthcare professionals, you're above the patients. It's hard to say that you're communicating equal to equal. Person depends on you. The person is afraid that because of the disclosure of the status, the quality healthcare is not going to be provided, service is not going to be provided, or disclosure is going to be done. For example, there is a woman who sits in the hall. Doctor comes into the hall and says, Mykola, your documents. So these are real cases. It happens. We were talking about the medical secret at this moment of time. The better practice are in the private institutions because we may stay in the same queue. So what do we have? For example, rectal surgeon or dermatovenerologists. We might sit in one line and everybody is thinking whether they're contagious or whether they are not. In dermatovenerologists, for example, how far away do I need to sit away from this person? So at this moment of time in private clinics where I address, the practice is rather pleasant. I'm asked only regarding the surname. No one is asking me why I'm here. Everything was already clarified by the phone. They tell me the number of the office. For example, number 13. Somebody is sitting nearby. nearby and they're waiting for the number 15. I only know which cabinet am I going to. For example, I have seen some of you, and then we are going to see each other waiting for our doctor's appointment. It's better to say that we do not know each other. It might be done. Or this kind of uncomfortable situation is going to appear. It's rather sensitive information. I'm not going to be afraid to say it's intimate information. We don't know what's the issue. Maybe I'm visiting a gynecologist or dermatovenerologist to get this swimming pool inform or this information for dance class. And then there's going to be an information which is going to be spread that Hanna Litvinova was waiting to have her appointment because of her dermatovenerology disease. So yes. So what's it all about? So this trust between LGBT community and healthcare community, for it to be higher, it means that LGBT people are going to be addressing you more often. And how do you make it public that it does not matter that much for you, that you are not interested that much in how you're going to leave right now the doors, and it has never happened, and you decide for your own that for some reason you want to become a man, then you need to address your friend. Because in fact, I'm going to explain you. He works in Zaporizhia? No. Okay, good. Because I thought maybe we have the same person. Okay. That's not about a choice. That's about internal dysphoria, internal issues. Maybe from child age, they feel themselves like that. For example, they feel themselves as a boy, and then when breasts are being formed, you have this shock moment. Person might be under the pressure of parents, under the pressure of society. So it's not a choice. It's not something that I want to have right now like this, and over here I want to have something different. No, it's not my choice. That's what you have constantly inside yourself. That's not something which you choose. That's same about the sexual identity. There is the golden standard of lesbians. Do you know what is golden standard of lesbians? That's when person did not have any sexual contact with men. But that's a situation, it's about understanding yourself. In case you open, in case you are open to understand yourself, you're going to know yourself better. In case under the pressure you think something is wrong with you, it's not going to work out well. And Hannah is actually waving me with two of her hands, with two of her paws. Okay, let's say thanks to Hannah. I would like not just to say thanks, and I would like, during each conference, there is outstanding lecture award. I would like to say that this is the lecture which you're not going to hear in any other place. Something which highlights this lecture a lot. Let's give a round of applause to Hannah, because for me personally, this hour just went through. You're an amazing speaker. Hannah, thank you, thank you. I would like to add that Hannah is going to stay with us during dinner today. And in case you have any kind of questions which you would like to address personally and not in the audience, please, you are going to have this option. We are going to have another speaker, so let's use our.
Good afternoon, everyone. It's really nice to be with you all today. I feel a little bit of pressure coming after the last presentation and talking about gender-based violence at 5:30 in the afternoon. But please, I hope you can bear with me. So as Irina said, my name is Olivia. I'm the Protection Advisor for Care in Ukraine. I'm from Australia, and I have been in Ukraine for 362 days, so almost 1 year. So all across today, you've been having lots of great conversations about how to provide the best quality of care to the people that you're working with. Often you will be working with people who have experienced gender-based violence or sexual violence. So what I'm going to talk to you about now is how to take a survivor-centered approach. So how to ensure that you are always centering and prioritizing the needs of the survivor in a way that does not cause more trauma or more pain to them. But before we start, I want you to ask yourself some questions. So I have 5 questions for you, but I'm going to get you to answer them individually in just a moment. So if you can please scan the QR code, you'll be taken to some questions. For each question, you will be asked to pick strongly disagree through to strongly agree. So it's 1 if it's not true for you, and 5 if it's very true. So don't worry if you didn't finish. It's just to get a sense of the level of expertise and experience that are already in the room. So in terms of the first question about do you feel confident that you know how to respond if a patient discloses to you that they have experienced gender-based violence? We're at 3. So that's the feeling in the room. So quite a few people feel confident, but nobody's super confident. If we look at the second question about receiving training on a survivor-centered approach, it's a little bit less. When we talk about a trauma-informed approach, it's a little bit less again. Then for training in psychological first aid, it's maybe slightly more than half of the people here have received some training in this. And then the last question, which is often the most important, is do you know how to refer a GBV survivor for other services? And this one is one of the lowest. It is impossible to be an expert at everything. Yeah? But what you can do is know who the experts are for other services. So when you are meeting a survivor, knowing who can you refer them to, what other services are available that you can support them to access. That's very key. So I know some of you will be very familiar with this, but I just thought it was important to touch on some definitions. IT problems, great. So, gender-based violence. This is a term that we use to describe violence that is committed against somebody because of their socially ascribed gender. It can be many types of violence. It can be physical violence, sexual violence, psychological harm, coercion, or deprivation. So there are many types of GBV. You may also be familiar with the concept of violence against women, and sometimes it can be confusing, the difference between gender-based violence or violence against women. Violence against women is a type of gender-based violence, and we know that while both women and men and people of diverse genders can experience violence, the majority of people who suffer from this are women and girls, and the majority of people who perpetrate the violence are men. That doesn't mean that men and boys can't experience gender-based violence. Absolutely they can, and it's very important that our services also support them. But we need to acknowledge that the gender dimension of this violence is very skewed in one direction. And so any programming we have around gender-based violence needs to consider gender inequality and how we can try and make all services and our society fairer. Then probably you have heard the term domestic violence as well. This is another form of, often another form of gender-based violence, but it's what happens within the family or within the home. So as I was mentioning, we have several types of GBV. Physical violence is probably the one that people find easiest to understand. Yeah, it's the most obvious one. Yeah, it's very clear. There's no need for interpretation. Physical violence, it's black and white. Yeah, it happened or it didn't happen. And so physical violence can take many forms. It can be slapping or pushing, as well as much more serious violence. Sexual violence is also a form of GBV, which you have been talking about a lot today. And sexual violence is any violence or any action of a sexual nature that is unwanted, that is without consent, or that is perpetrated against a child or in the presence of a child. Now, GBV can also be economic violence. This one is more difficult to understand straight away. But if you think about power dynamics within a family or within a relationship, the deprivation of access to financial resources is a form of economic violence. If you control the money in a relationship, you have all of the power. You control that other person completely. And often in cases of GBV, economic violence might be the first type of violence that begins in a relationship before it escalates to other forms of violence. We also have psychological violence. This is things like bullying, verbal insults, humiliation, using language that pushes the other person down, that is causing harm to their mental health. This is also considered to be a form of gender-based violence. So as I mentioned before, when we talk about GBV, it is not a women's issue. It is not something that only happens to women and girls. We know that throughout the world, it has a greater impact on women and girls, but it also affects men and boys. And particularly during a war or a crisis, men and boys can also be subject to GBV more often. But also, the point I really want to draw your attention to at the bottom here is that women alone cannot solve GBV. To respond to GBV, it takes the whole of society together, and we have to engage men and boys in doing this. I wanted to share with you some terminology that you might find useful in your work. I know in Ukrainian you have a few different words to talk about victims, whether it's like a legal terminology or other, as well as survivor. And language is really important. And when we are talking about GBV survivors, the reason we use the word survivor is we're trying to use a term that focuses on the strength and the resilience of that person, and not use a word that defines them by a crime that was committed against them. However, the most important thing is to allow the individual to choose the word that they feel describes their experience. So we can talk about victim survivors or just survivors, but really it depends on how the individual feels and the words that they want to use. And the word they use for themselves may change over time. Initially, they might feel like a victim, but over time, they start to feel like a survivor. So again, it's not dictating to someone how they should feel, but using language that tries to empower that person to make their own decisions. So unfortunately, GBV exists in every single country in the world, in every society. It's an unfortunate fact at the moment. In my own country, in Australia, where we have no war, where we have a high standard of living, lots of legislation that protects women, even in my country, 1 in every 6 women has experienced physical or sexual violence by her partner or former partner. While for men, 1 in 16 men has also experienced this. So it's important for us to acknowledge, regardless of what the statistics say legally, we know it's happening because it's happening everywhere. But during a war, during a crisis, those rates increase even more because the normal social fabric is not operating in the same way. What this means for you as healthcare providers, it may mean that people who've experienced conflict-related sexual violence are more at risk of unplanned pregnancies. It can increase the rate of maternal mortality and morbidity. It could result in injuries to sexual and reproductive health functions, and of course, increases in sexually transmitted diseases. So that's the kind of sad reality at the moment. But what I want to talk to you now about is what you can do. So a survivor-centred approach, kind of like I was talking about the language before, but a survivor-centred approach is about ensuring that the rights, the needs and the wishes of the survivor are at the centre of everything that you do. It's about ensuring that that person is supported to make their own decisions, even if you don't agree with those decisions. You can provide medical advice, but you can't give them an order or a direction. Yeah? You have to give them the options and allow them to make an informed decision. Experiencing GBV can be very traumatizing, and people lose their agency. They lose their ability to make decisions. So as a medical provider, the last thing you want to do is to continue to take decision-making power away from that person. Yeah? You want to support them to make their own decisions, to get back their agency and sense of self. And that's what we mean when we talk about a survivor-centred approach. So, some types of questions that you can ask. So, open questions. So, asking people things like, oops, how can I go back? There we go. I've pressed the button too many times, it's not happy. Oh, now it's going on its own. That's not right. Sorry about this. This is when I'm trying to click on things in Ukrainian while looking at English. It's a bit complicated. Can we go back? Back. Yes, this one. Perfect, thank you. So you should ask opening types of questions. So encouraging the person to talk to you, but not putting words in their mouth. So this could be, tell me more about what happened, or how were you able to get to a safe place? Sorry, can you go back again? Can you go back one? There's supposed to be questions here, but you can't see them. We try and avoid closed questions because this can force a person into picking one way or the other. And what we definitely don't do is ask why. So as a medical provider, you should never be asking the person, why did you do that? Or why did that happen to you? You're not there to judge them and you're not there to blame them. Healing statements are also really important. So these are things like saying, thank you for telling me. Someone in Ukrainian. It's fine. So these are things like saying, thank you for telling me. You can say to people, you're really brave for telling me. Acknowledge that it might have been difficult for them to share that with you. You can build trust by saying things like, I believe you. Often survivors are worried that they won't be believed. So having a medical provider say, I believe you, can be really powerful. You can also say, I'm sorry. I'm sorry that this happened to you, acknowledging that it was very difficult for them. So some guiding principles that you should all be taking into account as medical providers. Treating survivors with dignity and respect. Respecting the survivor's right to choose. Maintaining their privacy and confidentiality. Honouring the principle of non-discrimination. And lastly, providing the full amount of information to survivors. All right, so I think I'm almost at time, but I'm just going to show you a very short video to wrap up.
Відео включіть, будь ласка.
Gender-based violence is among the most widespread forms of violence. Women and girls are especially vulnerable to GBV, but it can also affect boys, men, adolescents, elderly people, and those with disabilities. This film is for humanitarian workers who may meet people disclosing GBV incidents during humanitarian crisis. GBV incidents are often hidden, and supporting survivors is always complex and sensitive. If a survivor approaches you and discloses an incident, ensure that any urgent needs receive immediate attention and that you're both safe. Listen carefully and treat any information given as confidential. Do not ask details. Do not record any information about the incident or the survivor. Inform the survivor of the options available to them. Only share accurate and up-to-date information about services available in the area and explain how to access them. If you are asked to help contact any type of service, the survivor must understand and agree to who will be informed and what will happen next. This is informed consent. If they give their consent, follow the referral pathway defined by GBV specialists in your area. Respect the survivor's choice. Do not counsel them or try and force assistance. Do inform them that help can also be sought at a later stage. Regardless of if a survivor chooses to access services or not, do not share details of the incidents or personal identifiers unless the survivor asks you to do so. Remember the key principles of safety, consent, confidentiality, and respect. You can only offer support if the incident is disclosed directly to you by the survivor. Under no circumstances should you look for GBV survivors. This can endanger them and yourself. If someone other than the survivor approaches you, give them information about available assistance that they can share with the survivor. Explain that safety and confidentiality must be preserved. Training and guidance from GBV specialists are essential to understand how you can assist survivors safely. Ask your manager what's available. You and your team should also be familiar with your agency's code of conduct and know that any sexual exploitation or abuse by humanitarians is strictly prohibited. If unsure of what to do at any point, seek advice from a GBV specialist whilst upholding confidentiality.
Okay, thank you very much. I think I don't have any more time, but maybe one or two questions. If anyone has any questions or reflections on how this applies in the Ukrainian context.
Друзі, запитання до пані Олівії. Я думаю, трошки сьогодні вже втомилися, але на завтра запитання, сподіваюсь, вже будуть. Олівія, безмежна
So today it
подяка.
seems like people
Дуже
are
дякую. Я знаю,
tired,
що
but maybe tomorrow there's going to
аплодисменти.
be questions. Olivia, thank you so much. A round of applause.
Всі
to you. Thank you.
аплодисменти це вам
So
за
this round
чудову
of applause is
доповідь.
Dear Rich Wemerman, are you here with us? So I kindly ask you to wear your headphones because Director Wemerman is going to talk in English, and in order for us to listen him in Ukrainian.
Yes. Good morning, Ilich. We are all here, and please, you could free to speak.
Great. Good morning, everyone. I'm glad to be here online with you. My name is Ilyich Wemerman. I'm the interim country director for CARE in Ukraine. And I would like to welcome you to the Sexual Reproductive Health and Rights Conference hosted by CARE and supported by the Ukraine Humanitarian Fund. It's truly an honor to be here with you today, to be among so many medical experts, practitioners, advocates from diverse backgrounds, all united by a common mission to advance sexual and reproductive health and rights for all individuals in Ukraine. We're here because we believe that access to comprehensive sexual and reproductive health services is a fundamental human right. As healthcare providers and advocates, each of you plays a pivotal role in shaping a future where everyone has the resources and knowledge they need to make informed decisions about their bodies. And we know that SRHR needs in Ukraine are very high, particularly in this context of this war. And your work is crucial in dismantling obstacles, addressing inequalities, and creating systems that are inclusive and equitable. So a little bit about this today's conference. The aim is really to create an environment of learning, collaboration, and empowerment, and to close the most urgent gaps that we have in knowledge around SRHR. Over the coming days, we will share insights, explore innovations, and discuss strategies to improve access to sexual and reproductive health services. We are here to challenge norms and inspiring conference. Thank you very much.
Thank you, Ilich. Дуже дякуємо.
Thanks so much. Thank you. So we're not going to have a lot of online participants. I would like to say that that's the only online participant. We are going to have live communication mainly. And right now, I would like to give a mic to my colleague Deya. Deya, who is the grant manager, actually head of this huge project.
Right. I'm very happy to be here. So as Irina said, my name is Deya. I'm originally from Albania. I've been working and living in Ukraine for 2 years now in Lviv, Kyiv, and have had the opportunity to also travel a bit around. So I would like just to say a few words to welcome everyone once again in this event of our project that is supported by the Ukraine Humanitarian Fund, UN, and also CARE as well. So we are encouraged to see so many of you have made it here and found time in your busy agenda to learn together, and it proves how important these platforms are. We are looking forward to share experiences, to collaborate together, hopefully on strategies that can strengthen and help protect sexual and reproductive health and rights in these challenging circumstances here in Ukraine. So a bit about the project is 15 months. Originally it was going to be 1 year, but we managed to get 3 more months, and CARE is directly leading on this activity, this 3-day activity, but also other components of the project also focus besides sexual and reproductive health. We also work on multi-purpose cash assistance. We also work on protection. We work on shelter together with our partners. And our focus has been women and girls in the south of Ukraine. The project will be finishing end of October. So this is one of the key activities, this 3-day conference, and we are very confident that it will be very productive. So the humanitarian crisis in Ukraine, as many of you know, has made the urgency and importance of integrating sexual and reproductive health.
Good morning. Ira has already represented me, Anna Dovhupol, and I'm going to help Irina and the whole team to facilitate our conference. Just a couple of words about the way of working. In case you're the speaker, please take a place here because we have an online broadcast and we have online participants. We have more than how many? We have more than 700 of participants which are registered. So for everybody to hear and to listen to you, please stay here. It's comfortable to stay over here. We have an interpreting, so I kindly ask you not to talk as quickly as I do. Yes, that's due to translation and interpreting which is available. And also we have a rather tight agenda. You saw that agenda is really tight. Me and my colleagues, we are going to be the one which are going to follow in the time. I have this 5 minutes, 2 minutes left. In case you are going to have over the time, I'm going to turn on the mics, as it to start our conference. Irina Voloshina, I kindly invite you with your topic. Irina, who is advisor of Sexual and Reproductive Health and Rights Advisor, Care Ukraine PhD, with her topic regarding the sexual and reproductive health during the humanitarian crisis in Ukraine. So please, Irina, we are going to have time for Q&A session. In case you have questions, please take a note on them. Please. Thanks so much. Thanks so much, Anna. And before we move to the slides, I would like also to make a round of introduction, so to say. Why? Because I am convinced that those who are present right now in the audience, they do not know each other. Because the registration on this conference, it was happening rather quickly, as you know, and I would like to say that the presence in this audience, of course, the advantage was provided to those who directly work with the targeted regions, Mykolaiv, Kherson regions. So please raise a hand who is coming from those regions. Thanks so much for you coming here. And also huge thanks to those who are from Lviv and from other regions, our partnership organizations which are here physically and which are in the audience. We greet you as well. And I would like to remind you once again, the main aim of this conference is to collect medical healthcare professionals, because among you also there are non-medical professionals, but those who have no medical background, they support medical institutions also in their projects. And medical healthcare professionals which are gathered here, you are according to your specialties, because all of you were indicating your specialties, where and who do you work as, you are the first primary contact healthcare professionals. What does it mean? That in the humanitarian crisis environment, people may address you on different causes, but these causes might be also associated with providing services in terms of protection of sexual reproductive health, HIV testing, pregnancy consultation, it might be family planning, it might be the oncology screening question. So that's why we have gathered, for the first time in Ukraine, I would like to say, this kind of interesting group. Because usually obstetricians and gynecologists are gathered, or medical nurses, or other type of practitioners. But we have this interesting mixed community where we have this first contact, primary contact practitioners all gathered in one audience, in one hall. The conference is planned unusually. For the first day, we are going to talk about the legislative points, and we have a powerful team of medical lawyers who deeply specialize in providing consultations to people during the humanitarian crisis. They are gathered here, and you're going to communicate with them. And I know that for healthcare professionals, it's not easy to communicate with lawyers, especially now. So please use this opportunity, ask questions, stay active. Because our dear lawyers are going to be today with you for the whole period of time. They are going to deliver a lot of interesting topics. We are going to talk about really sensitive topics. And there is one thing over here. Despite the fact that you are healthcare professionals, in case any topic is highly individually sensitive to you, because we are going to talk about the clinical management after gender-based violence, we are going to talk about management of adolescents. So in case you have any kind of issues or you feel yourself uncomfortable, we do not judge anybody. You may just leave, you may get your mental health in order for you to stay in balance and then get back to the hall. But discussion is being greeted in this audience. So please feel free yourself. Feel free. Ask any kind of questions for us to have no questions left unanswered today. What else was planned during these 3 days? We have planned to have workshops. In case you have your agenda opened, you're going to see that tomorrow and day after tomorrow, in the small audience, in the small meeting room, there is a specially organized urgent state workshops, because every healthcare professional once a year is needed to be trained on the urgency care regarding providing the care in case of anaphylaxis or in case of the bleeding and how to stop the bleeding. So we are going to have this workshop tomorrow. We are going to have two groups. It's going to be basic life support with automatic defibrillators and how to use them. Please, registration is done over there, and we have a limited amount of people there. The groups are limited. So tomorrow, 30 people are going to have this opportunity to get trained. The day after tomorrow, anaphylaxis. Providing care in case of anaphylaxis. Those who are not trained, I highly recommend you to go through that, because that's something which we are not going to need, I hope, but everybody needs to be aware. Also, we are going to focus on how to provide this care when we face pregnant patients, because sometimes it is not being discussed. Why I say that? Because I hope that a lot of you know me. I'm also a healthcare professional, and I have a couple of specialties, and I always tackle a lot of educational projects. Regarding the organization, do you have any questions regarding the organization? Okay, you do not have any questions, but in case you have any, please feel free to ask. Let's get to our main topics, our slides. What do we have here? Okay, so yes, there is an ear alert. That's how it is happening today. Ear alerts might be happening. So let's start to how actual this topic is and why we have gathered here today. Regarding the actual, I think you see the text on the screen, and I think that it is important to say that we have a mass displacement of population within the Ukraine and outside of Ukraine. We have a lot of those who were injured. We are talking not only about civilians, we as healthcare professionals are also under the influence, because more than 500 attacks were registered among the medical institutions, and also around 5,000 of deaths among the healthcare professionals. And it worsens the access to the sexual reproductive health services. What was observed? From the beginning of the full-scale invasion, the amount of violence among females was increased, according to the official statistics. Also, based on the different sources, it is well known that we have a lack of access to the clinical management after the gender-based violence. We have limited access to the family planning and also the services regarding the safe abortion, safe. That's something which I have heard personally. For example, the contraceptives, also contraception services, it is not staying free of charge, even during the humanitarian crisis. Taking this into the account, Care Ukraine is one of the structures of the huge international organization Care International. Care Ukraine is actively working in order to solve these issues which are associated with the sexual reproductive health in the humanitarian crisis environment, and this organization has a huge authority all over the world regarding the projects which support healthcare institutions and other organizations in order to improve access to the healthcare services. And starting from this full-scale invasion, I would like to say that Care Team has done a lot, and also a lot of other topics which they're being trained on. So it was my last slide. You have my contacts over here. Those who need them and those who find them beneficial, please take a note. And please, Anna, that's it from my side. Dear colleagues, we have a couple of minutes to have Q&A session. We have 9 minutes. In case you have any questions from the audience, please raise a hand and I'm going to bring you the microphones. Okay, yeah, some tables have microphones, some do not. Good afternoon, my name is Zoya. I am from Smile Foundation. We plan to work with you in Kherson and Mykolaiv regions. And I have a question. I have a background working in other international organizations. And I would like to say that this organization is trying to implement these services. And I was working at HIV people, that's something horrible. And I was constantly telling them, where is your deontology? What is your ethics? I do understand that in the higher medical institutions, deontology is being taught. But whether for our colleagues, for our obstetricians, for our nurses, for our healthcare professionals, doctors as well, whether we are going to have some kind of ethical standards which are going to be implemented, because that is something which is needed to be taught. It was horrible for me to hear this unethical topics. And also we had a huge issue, pediatric gynecology. I have not seen whether this topic is being covered within this conference, because there is a huge urgent need. We cannot make medical nurses to learn that, but also a lot of obstetricians have left the country. So thanks a lot. Zoya, thanks for your question. Regarding the first question, stigmatization and professional burning of healthcare professionals. Why healthcare professionals say it so? Why they name with this kind of words those who live with HIV? Also, this is regarding the people who have TB, who have diabetes. First of all, this stigmatization is the result of the professional deformation and burnout. In case this is the attitude which healthcare professionals have to their patients. Because you're a doctor today, tomorrow you're a patient. You need to understand that. And professional ethics and professional behavior was already highlighted by this organization, which is protecting people who live with TB, tuberculosis. There was also a course on the channel on the Ministry of Health Care of Ukraine, how you may name people with certain conditions, how it is not ethical to name them so. So what kind of legislative responsibility might healthcare professionals have? Sorry, it just pushes people away, pushes patients away. Those people who are going to be named so, they're not going to address healthcare services after being named so during the services. So the question of responsibility, whether it is an issue for the healthcare professional from the legal point of view, that is the question which is going to be commented by our lawyers, whether patients have a right to go to court, for example. We are not talking about GPs, we are not talking about doctors, we are talking about any kind of healthcare professionals. For example, when you're just being registered in the healthcare institutions, but you've already addressed inappropriately. Like, for example, this is the man with the syphilis. So, the responsibility of the healthcare professionals due to the unethical behavior, we are going to have our lawyers who are going to deliver this information. We are going to listen to them. But according to my opinion, their responsibility is not going to come from lawyer, and it's not only a patient medical institution in the court. It should be also within the ethical code which should be present in healthcare institutions. Every medical professional works and operates in certain healthcare institutions. For example, Yulia is the head of the private network of clinics in Odessa. And Yulia, as director, she might introduce an ethical code. And in the ethical code, it might be mentioned that in case it is unethical behavior, you're going to be fired with a certain fee even. And director of the institution has full right to introduce those ethical codes. So education and trainings should also be provided. It should be explained that's not the way how to treat people. We name them people which live with HIV, people which live with diabetes, people which live with other chronic diseases. Only appropriate wordings. And the second question, I'm so sorry. What was the second question? Pediatric gynecology. Yes. Pediatric gynecologists, we do not have a lot of them. But whether they need to be separated as healthcare professionals, I would like to talk with our obstetricians, which are going to be our speakers. These are going to be questions during the second and third day. We have Volodymyr among us, who is one of our experts. Because that's a question, how many of those specialists do we need in our country? I don't think we need a lot. The question is, what do we expect from them? And the first thing what I would like you to pay attention to, and during the previous conferences, I have never seen that the topic of virginity status being established. That's something which exists. Sometimes it is being written, the status of virginity. Anna is smiling right now. But yes, that's a state which among healthcare professionals is not being discussed. And our healthcare professionals, obstetricians, think that this is normal to write it so. So I kindly ask you to discuss this topic, whether it might be done. What is the responsibility which is carried in other countries, professional responsibility, and what do we do with this in Ukraine? I would like to talk about that. Okay, good. Ira, you're perfect on time. Let me stand here. Right now we have half an hour to have a coffee break. Coffee break, that's something extremely important. So please, let's respect the agenda. We are waiting for you here at 11:30. And in case you have any kind of questions which you are unable to ask, I think you may catch Irina during the coffee break somewhere in the meeting room. Thank you.
I think everyone's back. Still, we have 1 minute left for the participants to take their seats. For those online, just to remind you that in YouTube, you can ask your questions in the comments under the video, and these questions will be voiced after the presentations. That's ideal timing. So now I'm very glad to invite Katarina Shunevich, the head of Analytical Center UrFem. So this is the Association of Women Lawyers in Ukraine. And Katerina is going to talk about reproductive rights. So what are the limits of state involvement in women's privacy? And she has half an hour for presentation and then 10 minutes for questions. Hello, hopefully everyone can hear me and everyone's already woken up. So it's a big topic. I will concentrate on main aspect that our association is working on. I will tell you about services that we are providing, and maybe we'll focus on some problematic issues that I believe are really important to talk about, to tackle, or to start the discussion during this presentation. And I understand that you are working on respective sites, and the theoretical or legislative part could be commented by you based on the specific examples, practical examples that you have. So this is Association of Women Lawyers of Ukraine. It unites prosecutors, judges, lawyers, and other specialties, and to develop policies and practices and advocate for them. To prevent discrimination in the area of gender equality. So this is the divisions, analytical center I represent, education center, support center, and communication department. And I will tell you more details about each of those. And this is full information. Here is our website. You're most welcome to get in there. And there are some information about reproductive rights, best practices, translations of international guidelines and directions of our work. Everything is described there just to make this information available. Analytical Center UrFem that I represent is to develop legislation and working with key subjects like Ministry of Internal Affairs, General Prosecutor's Office, Social Policy Ministry, and others, just to make this legislation sensitive. Yes, I will try to speak more slowly. So we are working the area of developing legislation, and we do a lot of research, including foreign experts. The friends who has questions to Ms. Katarina. So in our chat online, because 532 participants are online with us, but the overall number of people is over 700. Questions come from different regions of Ukraine: Kherson, Odessa, Zaporizhia, Cherkasy, Kiev, Kharkiv, Khmelnyk, Lviv. Dear friends, greetings to all of you, first of all. There are no questions in the audience. Yes, so there is one question in the audience. Lilia, do you have a microphone? Please come up here. There has to be a microphone, but please come up here. Thank you. So if doctors do not have questions, I will, with regards to informed consent. As far as I understand, and we probably all faced with that as patients, but I do not fully understand how this problem can be resolved. Because if you don't sign the informed consent, doctors say we are not going to do the procedure. Or if I tell them, like, I agree to that part, but I don't agree to that other part, they're not going to do it this way. It looks like there's no way out. And we are, as patients, are very vulnerable, especially women who give birth. They're more vulnerable. Thank you. I will focus on two aspects. Number one, theoretical, how it should be. Second, practical. Number one, I already mentioned, we have a normative regulation. We have an order with regards to domestic violence, but it should be broader with regards to what to do on part of different agencies like healthcare and law enforcement facilities, what to do if it is a sexual violence. But based on that order, a special protocol has to be developed for a healthcare worker. For example, if it's a sexual violence, what's your algorithm of actions? Because on average, it looks like we have only 12 minutes average time for an appointment, and to identify a case is difficult. A person might not be ready to voice that. A person of informed consent. It's about dental interventions, also beauty clinics interventions. Probably you all heard about that last case. You're most welcome.
Yeah, Katrina, me as a person who is an orchestra, for a long period of time I was working in the pathology for a long period of time, and one of my main friends is an expert. We have this expertise. So, whom should I reach out in order to understand? We know in case there is sexual violence which happened. Whom do we need to reach out? In our plant, for example, NGOs. We have 20 NGOs. We may do a lot together. But the subject who has the authority to initiate the legislative changes, that's a completely different subject. So please, I encourage to have the discussion with the representatives of the government. Katrina, when we have any kind of communications with healthcare professionals, I always show your site, your website. And I recommend healthcare professionals to know that they might address you. So could you list a couple of examples or cases when you need to be addressed? What kind of legislation support is provided? What does it cost? How much does it cost for those who are victims? So all services are free of charge. We just need to be reached out. We work with sexual violence. What do we talk about? Exact cases. 2 years ago, there was a sexual violence by a physical education teacher. There was data which indicated that the pupil, the girl, was under the sexual violence of the physical education teacher. Also, those who are serving in the military. Also, and so, yes, that's the format. Thanks so much. You have a lot of hearts in the chat. Okay, any kind of other questions? Okay, so you were discussing something. Maybe you're going to give us a comment. Okay, no? Okay, good. So these are the questions which cannot leave you without any kind of emotions. So Katrina, in case there are any kind of other questions, could we send you those questions in a written form? Yes, sure. You have all the contacts, so you have the contacts of the organization. Feel free to reach out using the email, and we may also encourage other experts to have a discussion. Sure. Please. We are going to move forward. Yes, Natalia, please. Okay, I'm going to ask right now to have near the mic Natalia Rodionova. Natalia Rodionova, please. I'm going to read out all of your information. Natalia is a lawyer. She is mediator of the Restorative Justice for Minors, project trainer in the implementation of international standards of the treatment of children in context of conflict with the law, expert on protection of children from violence, member of Pravo Ye NGO, Ukrainian Women Lawyers Association, URFEM, Youth Committee of the Ukrainian National Bar Association, UNBA Next Gen. So she's going to talk about the legal aspects of counseling for adolescents. So Natalia, you have time till 1 p.m. But please consider that we need some time for discussion. Yes, I'm also part of the URFEM family, and I would like to add a little bit regarding the previous lecture. We work with also psychological support, not only for adults, but also to adolescents and children, which address us. And right now, we have been following on their cases. So today we are going to talk about the legal aspects of counseling the adolescents. I would like to start with the following. Okay, so my contacts. I have a little bit of a different principle, so I have started with my contacts. Okay, and so really, adolescents, they are rather vulnerable. Why so? Because they are not that well known around their rights, which are regulated on the international and national levels. Also, that's some psychological and physical development. And sometimes it's just hard to deal with adolescent. But based on my practice, when we talk about the cases of sexual violence, ordinary sexual violence, I have quite a lot of cases when adolescents were addressed using our hotline. They were listening about educational materials, or they found out in the public information the possibility to address for protection. And the first thing they face, that's distrust. Nobody trusts them. And that's an issue where we as adults need to support them and need to evaluate this situation, the real situation. So legislative basis, which actually has these rights. Of course, that's Constitution of Ukraine. That's the basis about the equity, about the right for the healthcare, right for the life. This is the Civil Code of Ukraine, which actually on the common level describes a lot of medical issues. Also, the basic legislation on the healthcare. Also, law of Ukraine regarding the prevention on the home-based violence, because it also covers adolescents, children which are suffering, and sometimes their legal representatives or those who are performing their legal representative function, they might be the one which perform the violence, and that might be observed by teachers or by healthcare professionals when, for example, adolescents address with a running nose, but they observe that there are traumas. Also, there is an order by the Cabinet of Ministers of Ukraine regarding the protection of the children which are in the complicated life environment, and also how to work with the subjects.
Besides, it's about flexibility. We don't have to use the stereotypes when usually people, we do not value them because of the age. We do not have to tell them that you don't understand the situation, you understand it in the wrong way. So they say that parents like they beat me, and you don't tell them. That's maybe because you didn't like wash dishes or something else. So that might happen. That could be a real criminal case. Maybe not, but maybe a criminal case. So we really need to always be objective, and we always have to be professional. And we don't use the diminutive names towards them, like honey or whatever, dear, or because they want to be perceived as adults. So these are the most important things. Thank you so much for listening to me. What are the questions, if any? Please, one by one. Hello. Thank you very much for your presentation. Very interesting. So, since which age? I'm a gynecologist. Since what age we can do a gynecological examination? Say, for example, 15, and there are some complaints, positive tests. So, question number one: do we have to invite official representatives? This is number one. And number two, if a child is 13 and there is complaints of violence, so what do we do? Where do we go? For example, we do not have a psychologist, or we do not have any accessory, so to say, things or specialists. And number three, if we invite colleagues, that means breaking or breaching confidentiality. And there was a case when people just leave. So nobody is waiting that, yes, people come and tell them. So, and this is a real case. So you want to invite someone, they just get up and go and leave. All right. And then if you talk to your colleagues without that legal representative, official representative being there, so that means that the court would not take that as a proof. So what do we do as doctors in this? So let's start from number one, age. So 15, 13, 15 years of age. So according to legislation, from 14 years of age, a child has a right to choose a doctor. So a child can come to a specialist, see a specialist to get help. We don't need parents. With regards to 13 years of age, difficult to say here. We cannot say no. So if a patient, so to say, comes, we cannot just say no. But in order to understand better what's going on, we still have to explain to a child that in case if she reports sexual violence, it's going to be regarded as criminal case. So that means that legal uh, representatives need to be involved. If a child says that that was one of those legal representatives of family members, unfortunately that happens, I believe here it's better to explain first that we have to help you, support you, but in order to do that, we will need to report the service, the agencies, and the police. If she has other legal representatives, full-aged, for example, family members, a brother or sister or a grandmother that she trusts. So she might come together with them. It's not a breach of confidentiality if it's not a parent or one of the parents, but still, if in future we will need to have a representative in the law enforcement, so the legal representative will have to be involved there. But here it's important to know who was with the child from the very beginning. And even when we report to the service on children, for example, there was a case in my practice of family violence, domestic violence. The child was 14, but doctors gave us a conclusion, like a report, because she actually came to the hospital and she had a trauma, that was father was beating her because she was not doing the right thing. So the doctors gave that report to us. For example, that we've identified such and such injuries, whatever, whatever, and that helped us in court later on. And without mother being present there, the child, when communicated to the doctor, she said, like, I'm afraid to go back to my home because she was afraid of her about her life. Also, there is another question. Microphone is important because we have a translation. Hello, thank you for your presentation. So practically, I had the same questions as you already actually answered, but clarification. So appointment, any doctor can see a child, 14-year-old child. Any doctor of any specialty can examine. Yes, I see. Second question: a gynecologist has a right to examine a girl if there are some complaints. So without parents, without anyone being, of course, yes, because there are complaints. Yes, they can examine. Okay, if, for example, a child who is under 18, HIV plus, pregnant, and the child does not know what to do with all that. So, do we have to notify? Do we have to notify parents or guardians? Or what do we do in this case? Thank you for your question. Considering that HIV is a socially dangerous disease, and we need to notify legal representatives, and we have to teach them, to educate them how to live with that and how to do everything in the household, and how to support the child taking ART in case they they say, we don't believe you, we're not going to give you your pharmacological poison. So then we need to report that, notify that to the service on children, police, because that means there is a violation of the right for health. Thank you, Natalia. But clarification again, if a child does not want the doctor to notify parents, so does the doctor really still has to do that? Because there is a collision in the legislation on adolescents that we have. On one hand, so the adolescent says and signs consent for care provision. On the other hand, there is a law saying that parents have the right to have all and to know all the information about the child who is under 18. But actually, there is no law uh, that might say that the doctor has to do that. So just for you, colleagues, not to be proactive when a child also has a right to confidentiality. Is that correct? Yes, it is a problem because in a case, so when we are all silent, nobody says anything, then healthcare workers can be liable because the parents say, well, they didn't tell us all the information. That is why we didn't organize all the care in the right way. So there is a lot of collision. We need to understand what's this family, what's the family, or how to talk to them, or maybe a child is very worried because it's too difficult information for him or her, or there is a crisis family, or there is specific religion that they have in their family. So yes, there is a collision. Can you tell us, a healthcare worker can approach a legal representative just for help? Because a healthcare worker practitioner is, it's difficult for healthcare workers. And last question before our lunch. I'm a pediatrician, and reproductive health depends on vaccination as well. Does a child has a right to agree to vaccination before 18, under 18? Moms can be against vaccines, but the children might want. What kind of vaccination you are talking about? If I may, we have a lawyer, Oleg Yudin. He is not with us here, but there is a wonderful book that he wrote about vaccination. And so, what he explains, what is vaccination? It's a preventive intervention. Can you tell me, preventive intervention, is it a harm? No, it is not a harm. So, even if a mom who is against vaccination comes to you and says, how come you vaccinated my child without my consent? But there is a signature of a child. A child is 14 or 16. There is child's signature, and it's a very good thing. And she will not be able to prove in any court that you've inflicted harm on your child. So that's how he explained to us as a lawyer all that thing. So time, dear colleagues, thank you so much for your attention. Natalia, thank you first of all, for everything you do for supporting people, for your activities. Bon appetit. We have our lunch on second floor. And at 2 sharp, please come back. We will continue. Thank you.